Hey everybody, happy Tuesday. Welcome to VMR. I'm here with Ravi today with a V, and we have some friends from Indianapolis today. We kind of have, people tuning in from all over the world, and I feel like we're circling back to the States here today. So, Deepa and Code, do you want to introduce yourselves and kind of let us know what you like about your program and maybe how you heard about us?
Yeah, so hi, I'm Deepa. I'm a PGY2 at Ascension St. Vincent in Indianapolis. And I'm here with my co-resident, Caitlin. I'll go ahead and introduce yourself
Yeah,
too.
sure. Hi, I am a PGY3. I'm doing the internal medicine thing. I'm planning on moving into outpatient after this, which is, I've been told I'm a bit of a unicorn. We are with the internal medicine program at the Ascension St. Vincent in Indianapolis. It's a community program. We probably both chose it for the community. It's a pretty popular response when people ask why we love this program, just because the community is so great. We just feel really supported by our program, and just there's just been such a great
Camaraderie.
yeah,
amongst
right.
Us residents and with
Yeah.
our staff and faculty, and I think Dr. Mehta, one of our
Yeah.
APDs, just joined too.
Hobbies?
My hobbies in my spare time, I spend a lot of time with my husband and my dog who's running around, and I hope she won't bark during this. But we like to go hiking. We like to cook a lot together and do things like that. About
Yeah, I am also married and I have a toddler as well. So one of my main hobbies is trying to keep her alive. We like to spend a lot of time outdoors and when the weather's nice. We just got a trailer for the bike, so now we're trailing the toddler around everywhere. She always wants to go for bike rides.
That is amazing all around. Thanks so much for being here. Thanks for bringing the case, and thanks for telling us a little bit about yourselves. And Robbie, you want to say hi real quick?
Oh, sure. Just comfortable sitting in the background, but I'm absolutely stoked to see Deepa and Caitlin bring a case in the middle of the week. Sometimes we do these on the weekend, but it's such a delight to have a case and a program be represented on CPS VMR. I just want to ask, like, how did you find out about VMR and how do you incorporate this into your learning and possibly teaching at your institution?
we listen to your podcast quite a lot. I think that we have our noon reports kind of similar to how you guys base your podcast, and I think that's how we learn, is how we clinically get to apply it. But
Deepa's the one applying for fellowship here, so she's trying to move on for bigger and better things. She was the one who, it was her idea to submit this case to you guys, and when I heard that you guys were interested in it, we were just so excited about it. So thank you so much for having us.
Absolutely brilliant. And I see Dr. Mehta has been. Oh, there's Dr. Mehta. Hi, Dr. Mehta. How are you? I understand
Hey,
you're one of the APDs there.
no, I'm not. No, I'm a core faculty. But
Oh,
actually,
okay.
one of our core faculties that speaks with you guys, I think twice a month. Jennifer Mundell. That's the other uh, avenue of how we heard about you guys. So
Brilliant, brilliant. So I appreciate you coming on today and supporting your wonderful residents here today. So should we get started? I think VJ, the whiteboard, and we can start with the first aliquot. Andrew, take it away with the first aliquot.
All right, let's do it.
I can go ahead and start. Or let me know when you're ready for us.
We can start while the whiteboard's coming up.
Our case is a 67-year-old male who presented to our institution for a headache and weakness of the left lower extremity that had been progressing over the course of a week. He initially presented to an outpatient facility for his symptoms and was counseled on hydration and using NSAIDs and acetaminophen for his headache. And then his symptoms progressed until he was unable to use his left leg due to weakness. He subsequently developed urinary retention and had been unable to void for 2 days, which prompted him to come to the hospital. During his initial evaluation and while we were trying to get history from him, we were going to obtain a CT, and he then had a grand mal seizure, which resolved with the administration of lorazepam.
We can stop right there. What do you think, Andrew?
Yeah, Robbie, whenever we talk about headache in the clinical problem solving space, we always talk about how kind of the epidemiology of headache kind of changes when you're in this setting, like the CP solvers world. Kind of the base rate for secondary causes of headache are higher than the primary headache disorders. And kind of the path there is through positive SNOOP findings. It's a mnemonic we use to look for kind of dangerous causes of headache that you need to look up further, kind of beyond these primary headache disorders of like tension, cluster, and migraine. And clearly here we're starting with a patient with multiple very concerning findings. We don't have their past headache history because part of the Snoop mnemonic is kind of like a change in characterization of a known headache history, but we don't even need that history here because we have a patient coming in with like a persistent focal deficit in the form of left leg weakness, urinary retention, and then of course the seizure is, I mean, we don't have their seizure history, but if this is a new seizure, it's all concerning. So taken all together, very concerning history. And I'm curious, Ravi, I'll just pass it off to you. Like within the kind of like the secondary headache space, does the focality here, the finding of seizure, does that help you kind of narrow the differential kind of in the secondary headache space?
You know what I love about discussing with a co-discussant is just like the approaches are very different. For me, the weakness in the leg was concerning, especially over the short period of time within a week. But you're absolutely right. This is sort of similar to yesterday's case. If people can revisit the case on YouTube, Kirtan and Shema did a fantastic job where you had this headache but you had also this abdominal swelling in this patient. So there was this systemic sort of presentation of a condition. So here you have primarily seems like a neurological issue, and between the brain and this headache and the lower extremity weakness, this appears to be not something outside of the neurological topography, but more within the CNS realm. So thinking about lower extremity headache, is this in the primary CNS realm, or is this maybe spinal cord, brain and spinal cord areas? So think if it's symmetric, I would think spinal cord like a myelopathy, and things that you usually think about would be compressive versus metabolic disorders, maybe drug induced, maybe infections. But here we'll see what else that Caitlin and Deepa give us in regards to like, is there a flavor of infection? Is there a fever here? Is there trauma? Is there with the age range? Is there possibly malignancy associated with this? Is there something then backtracking to your question about the headache? Yeah, I also think about secondary causes, primary causes, like you astutely had mentioned, there's no previous history of any, say, migraine or anything like that. And there's no prodromal surrounding any history surrounding this. So secondary, you start thinking of ominous causes. And I guess we'll do a deep dive into that once we get more information. But at this time, definitely CNS, especially one leg versus two legs. So if it's a myelopathy, you would think symmetric, sort of lower extremity weakness, and also sensory involvement. And I think this is a bit of an emergency now with patient having incontinence as well. So this definitely needs an urgent workup, especially imaging, because this could be a catastrophe for this patient if not addressed in a timely manner. Anything else come up, Andrew, before we swing the mic back to Deepa and Caitlin?
Yeah, I'm just trying to like squeeze as much out of this aliquot as I possibly can. And I'm wondering like if taking like a systematic approach to seizure can help us make progress in terms of what's causing the neuro symptoms. So the mnemonic I use for seizure is VMIS. That's like the MIS mnemonic for altered mental status. You just like tack on a V at the beginning. So vascular causes, you can think of vasculopathies and vasculitis doing this. That can cause, multifocal kind of findings. Metabolic causes, anything on the fishbone diagram that can cause seizure, like hyponatremia can do this, but it shouldn't cause things like urinary retention can cause seizure. It shouldn't cause like a focal finding, maybe it must be herniated or something like this. Infections, certainly on the differential, like meningitis, whether that be acute or chronic. Structural things, I'm certainly thinking of that here, given kind of the focal finding, and Robbie kind of alluded to this. And then toxic stuff, you can consider like alcohol withdrawal or acute intoxications of other things. So I think in terms of layering on seizure, I think we need to prioritize kind of structural causes. And I kind of like this idea of looking at the spinal cord because of the urinary retention, although that could be just non-specific from the patient being very sick very quickly. And then, yeah, I forget if I said infections already and structural. Those are the two I'm kind of most worried about on the seizure DDX. So it'll be curious if they have a past medical history of something that makes them like immunocompromised, kind of prone to weird infections. It'll also be interesting if they have like a cancer history where something is now kind of seeding the spinal cord. But let's get aliquot number 2.
Do you want to finish with review of symptoms?
Okay, so ROS was otherwise negative. He denied any fevers or chills, any like lesions or skin rashes, any difficulty hearing, any congestion, any chest pain or palpitations or shortness of breath, and any myalgias or back pain. And going on to past medical history, and that's okay with you guys. He had a past medical history of asthma. His medication was dexamethasone 0.75 once a day for asthma.
An oral tablet.
Oral tablet. He has no family medical history. He was here for social history. He was visiting the United States from China, and he had been visiting in camps throughout the Midwest, camping throughout the Midwest. He denied any alcohol use, tobacco use, or recreational drug use.
He is a Chinese individual by descent and spoke Chinese as his primary language.
And no known allergies.
Perfect. Maybe could you also give us the vital signs in the exam?
Yeah, absolutely.
So much.
So on physical exam, the patient was well developed, well nourished, no acute distress. Skin was warm and dry, no rash. His head and scalp, he was normocephalic, no evidence of any trauma. For HENT, pupils are symmetric, reactive to light, conjunctiva and eyelids are normal. His nose, no mass or deformity. Ears had no mass or deformity. His lung exam, he was noted to have bilateral wheezing, audible wheezing from across the room. For his cardiovascular exam, he was regular sinus rhythm. S1 and S2 were both normal. No murmurs, rubs, or gallops. For his abdomen exam, he was non-distended, soft, non-tender. Musculoskeletal exam, he was exhibiting some weakness on the left side, but joints and limbs were grossly normal. Neurologic, cranial nerves 2 through 12 were intact. Patient had bilateral lower extremity weakness, but the left was greater than the right. His left lower extremity was unable to appreciate plantar flexion. His leg lift was 1 out of 5. He was unable to bend knee at the right. Unable to bend his leg at the knee on the left extremity. On the right lower extremity, plantar flexion was between 3 and 4 out of 5. And he was unable to lift leg against gravity 2+. But he was able to bend leg at the knee. He endorsed full sensation over bilateral lower extremities. Otherwise, his upper extremity strength was full and equal bilaterally. Reflexes were 2+ and equal bilaterally at biceps, brachioradialis, as well as patella and Achilles tendons. He did have a urinary catheter in place, and from a psych standpoint, he was cooperative and pleasant. I can also give you vitals. He was febrile, 38 degrees Celsius, tachycardic at 113 beats per minute. He was normotensive at 137 over 91, maybe slightly elevated. I don't have respirations for you. Sorry.
That's okay. This is super helpful. Was there anything else on the exam?
I don't know. I think I said no rashes.
Okay.
I can't think of anything else that you need to know right now.
Super helpful. Ravi, I'll let you go first because you were already like talking about is this going to be unilateral or bilateral leg weakness? And I think that's really helpful.
Yeah, so very detailed, Deepa and Caitlin, like very detailed exam. I just want to applaud the extensive neurological exam because we're trying to solve what's going on here. Does the answer lie in the CNS or the peripheral nervous system? And I think with the seizure and the headache, there's something going on in the brain. And initially, when you said there's left lower extremity weakness, I was trying to map, okay, motor disease, maybe something in the brain on the right hemisphere. As you remember, in neuroanatomy, you have the corticospinal tract, which then emanates from there, goes through the internal capsule, down through the brainstem, and then decussates over to then produce left from the right to the left upper extremity, lower extremity pathology. But here we just have left lower leg pathology, but there's also some involvement of right. So then my mind thinks, okay, the tracts are probably affected lower down. And maybe in the spinal cord, are we then dealing with myelopathy or peripheral nervous system pathology here? And then with myelopathies, we start thinking about first tracking back to what I mentioned, is there a compressive disorder? But then you start having other things like metabolic disorders like vitamin B12, copper deficiency. You might have medications that maybe involve like chemotherapeutic agents. Yeah, if the patient's immunocompromised, like Andrew mentioned, could there be an infection involved? And again, brain and then also spinal cord. Is there something going on? Not too recently or long ago, we had a patient with spinal cord involvement due to urinary tract infection, gram-negative rods dispersing through Batson's plexus. So that's also something that's always sort of at the front of my mind. I've been sort of thinking about or cycling in my brain because something that I may come across in the future. But here we have a fever. I was kind of constructing, okay, the fundamentals of reasoning, a problem representation could bring all the salient features together and help us try to solve this. So 67-year-old male from, now I don't know if China could introduce bias, but I'll put it in there. The chat was pretty lively. China, TB, so a spot diagnosis right there, right off the bat was TB. But headache, seizures, acute presentation of headache, seizures, left lower extremity with some right lower extremity weakness, and fever over the course of 1 week. Just to simplify it. Now, the dexamethasone, what was he on the dexamethasone for? Because that instantly, to me, means there's some immunocompromised status. With steroids, you could introduce, if it's over a long period of time, adrenal insufficiency. So if this patient has acute infection, they're going to be adrenal insufficient. We may have to double or triple the dose. Or this patient is coming in with immunocompromised status due to steroids. As we well know, it does have a negative effect on our neutrophils and eosinophils and so on. So he could be open, like Andrew had mentioned, this patient could be immunocompromised. So just like yesterday's case of a patient with cardiac transplant, you could get a whole host of opportunistic infections. But yeah, just getting back to that, dexamethasone for how long?
I know he had been on it for an extended period of time. This was kind of a routine treatment for him that he was taking for his asthma, but I don't exactly know how long. We'll say at least a couple months to a year.
Okay. So then, yeah, that brings front and center in reasoning. I think infection likely, and infection is going to manifest in a whole host of different things, abscesses, masses, and so on. Some infections could also promote lymphomas anywhere. So lymphomas could be EBV directed as well, HTLV viral directed. Again, HIV we would need to get HIV test on this patient as well. But in my mind, if there's a fever, I think about could there be an epidural abscess with systemic hematogenous spread to the CNS. If there's anticoagulation, you could have an epidural abscess. If there is cancer, you can have metastasis to the CNS and also the spine. If this patient, there's no trauma with this patient that you mentioned, so this is not a traumatic compressive myelopathy. And our seniors may have a pre-existing history of spinal stenosis, which can cause chronic long-term, but this is acute, so I kind of would reject that hypothesis. But very much at this moment, I think infection, and I don't think the primary area may not be CNS, but there may be signature there or signal in there with maybe metastatic lesion or infection. And like the chat had mentioned, TB and a whole host of infections that could take place up in the CNS and also the spine. What do you think, Andrew, at this point?
Yeah, I don't have too much to add, Ravi, except just kind of my money with the kind of acute progressive nature of this over a week is kind of shifting me toward in the land of infections. And I think I'll just comment on like what we could do next to kind of make progress in real life here. We've talked enough about compression, I think, to look at the spine. And, because there's a focal deficit, this patient's going to get like his CT head, initially to rule out large intracranial abnormalities and hemorrhage. And then while we MRI the brain for the focal deficit, we also can just do the total spine while we're at it too, which is going to take a while. And then I get the sense that if that were to be negative and not show like a huge mass, or if it were to show something like leptomeningeal enhancement, something like this, I get the feeling we're kind of also going to need an LP and specifically some infectious studies from the LP to kind of make more progress. The other thing, in terms of like potential pivots coming, I do note that there was the bilateral Wheezon exam. So I'm wondering if what's inciting the CNS kind of started in the lungs. And, I'm primed from yesterday's VMR. We were talking about brain lung syndromes, but it is kind of curious if the pulmonary exam is going to end up kind of giving us true signal for something landing in the lungs and going elsewhere. And other than that, I think we can just move on to the labs. Oh, I'm sorry. The last thing I wanted to mention too, there are some like weird viruses and some other infections that can cause myelopathies and encephalitis. Some of these are arbo infections, so we'll be kind of curious if this patient has like leukopenias, some transaminosis kind of giving that signature of arbo infection, because that would also be a huge pivot just thinking ahead. But let's see what the labs show and what the initial imaging shows.
I just want to sneak in there. I think, Andrew, you just triggered a thought in my mind. This does open the door with dexamethasone to not just bacterial viral, but also endemic mycosis. So like yesterday, nocardia, though bacterial, this is an entry point. These organisms enter through the lungs, like you just mentioned or highlighted the lungs. So maybe something that's soil-borne, we don't have waterborne here, but soil-borne could have ended up entering the lungs. And from the lungs, then these sort of infections, as Keith had mentioned yesterday, and the description of if anybody read about nocardia after yesterday's VMR, it does cut through tissue planes. So we could be looking for something that cuts through to then end up in the brain and other areas. But then again, at this point, we shouldn't get too invested in infection because the fever signal here, it could also be a signal for inflammation. So it's systemic inflammation, like you had mentioned, transverse myelitis could be something of that nature, could be at play here. So, but I think just that the lungs here, trying to connect it, the lung-brain syndromes could be something to entertain here. Back to you, Deepa and Caitlin.
Okay, great discussion so far, you guys. So I'll give you some initial labs and imaging. Hematologic studies, the white blood cell count was 3.7. Hemoglobin 14.2. Hematocrit 38.7. Platelets 137. For basic chemistries, sodium was 138. Potassium was 3.9. Chloride 105. Bicarb 25. BUN 15. And creatinine 0.63. The non-fasting glucose was 183. I don't have the liver enzymes written down here, but they were normal. And then I have a CT of the head. Did not reveal any acute intracranial abnormalities. We can, if you want, we can talk about that for a bit, or we could, we have our next aliquot has a little bit more advanced labs and imaging.
Yeah, I think we could pause here. I'm not sure if we're gonna be able to make a ton of progress. But is the white count normal or low? After 3 years of residency, I don't know the lower limit of the white count. Low.
It's the white count is normal, and it's kind of on the low end of normal.
Okay, got it. Got it. Again, just searching for signal for kind of some of these arbo infections that can cause acute encephalitis, and that would leave kind of like a leukopenia, thrombocytopenia type picture. But the platelet count, it's like barely low. We don't even know what their baseline is. They may live around here, so I don't feel like particularly inclined to kind of latch on to the data in the CBC at this time, especially if the transaminases were okay. They may go up later though if nothing is done, and it's just the natural course of the disease. So we can just keep an eye on that. So
Maybe I should correct myself. It looks like that white blood cell count might actually be considered low at 3.
okay, got it. Thank you so much. So yeah, I'll like keep it kind of like in a pin for now, Ravi. I'm not sure if I want to put like too much weight in it, but I feel like that may end up giving us a clue. If the AST and the ALT were to go up, if those things were to get worse too, I would definitely be thinking of arbo infections.
Yeah, I think definitely, yeah, infection still is at play. What's interesting that just the CT being pretty much normal, no intracranial abnormality, we can at least start taking out hypotheses of space occupying lesions, malignancy, metastasis, space occupying lesions, and so on. But at this point, then we have to think about, like you mentioned, how's the brain integrated into this problem? Could there be inflammation, infection? We still don't have CNS. The CT won't show us unless we get a MRI. Maybe we can see involvement of say HSV in the temporal lobes and so on. But at this point, I don't think there's anything present other than maybe inflammation in the brain causing the seizure, the headache, and so on. And was there nuchal rigidity in this patient too? I remember.
No.
No nuchal rigidity. Okay, but it doesn't have great sensitivity specificity. If it's not there, it doesn't completely exclude uh, encephalitis or meningitis in this patient. What usually presents with seizures and maybe altered mental status, neurological deficits, usually encephalitis, but you could have extreme bacterial meningitis then cause or present like this. But encephalitis greater than meningitis presenting like this. But at this point, I think CSF is key because then you have to start. We're sort of like, are we now wandering into a domain of autoimmune phenomena, autoimmune encephalitis? And so is it worth sending those highly expensive autoimmune antibodies at this point? I'm not quite sure, but definitely I think there's still some workup to be done, which would be MRI of the spine and also getting some CSF. But just revisiting what we always tell our students for the shelf exam for step 2. So if somebody presents with altered mental status seizures, you have to get imaging before treating this patient for so-called meningitis or encephalitis. So you got the CT, which was fine, and then I wonder if would we start antibiotics? And then looking at the labs, like Andrew had mentioned, the white count is kind of down, so that still can be a signal. If we get a cell count, the neutrophils down, is this neutropenia? Is there lymphocytopenia? That could also help trying to define what's going on here. Anything else, Andrew, before we send the mic back to Deepa and Caitlin?
No, that all sounds good. Could you just make Deborah a co-host? Because I think we lost VJ from his connection, and she's thankfully volunteered to take over. Thanks, Deborah. And then back to our next aliquot.
Okay, great. I think we were gonna pass the baton to Dr. Mehta now.
Okay, so we ordered blood cultures because he was febrile, which showed no growth. We also tested HIV, which was negative. He did undergo a lumbar puncture, and the CSF showed leukocytosis with WBC of 1049, with elevated mononuclear cells at 94%. Protein in the CSF was greater than 600 milligrams per deciliter, and glucose was 63. Let me know if you want to stop or I can keep going. We also ordered an MRI of the brain and spinal cord. Okay. You want me to stop or keep going? Okay.
All right, Robbie, what do you think? Do you want the MRI? There's a lot to touch on the LP. The MRI brain will and spinal cord will be potentially another pivot. Should we stop here?
Yeah, I think so. Let's see what the CSF gives us. What are you thinking now?
Yeah, very inflammatory CSF here. The mononuclear side of things, I believe, gets us away from kind of typical bacterial infections and makes us think more of viruses, fungi, and atypical sorts of organisms. So it does kind of make me think of some of the viral diseases. And I don't know too many off the top of my head, to be frank. There's like West Nile virus. This person is in the Midwest visiting. I don't know if West Nile goes that far. It comes to the Northeast. I've heard of that before, so I wouldn't be like shocked if it's West Nile virus. Some of the encephalitis syndromes on the ARBO infection list. I think one is called like Japanese encephalitis virus, something like this. I don't know if that's present in China, and he was inoculated before coming and then just happened to get sick when he was here. So I think maybe some travel history could be helpful, and then some research into what sorts of infections could do this could be helpful to make sure we know exactly what's going on. Because some of these tests, they may not even be in like the routine kind of like PCR panel. So I'd probably want to know when this person got here to the States, where they were before, where exactly they went to. And then I don't know, some of these infections too could be like environmental exposures as well, Robbie, if we're talking about like, atypical sorts of organisms. So knowing like what sorts of like water this person drank like may be helpful as well. But basically I would be doing a history, and I would be doing a lot of research into some of these organisms because they're not something I'm super comfortable with. I don't know if Noah's still here. I'd be consulting Noah on infectious diseases.
Yeah, I think you did. I mean, I don't have much to add. Just at this point, I don't know if there is a certain organism which we can assign to such a pattern as depicted on this CSF. But yeah, I think we're now in the home stretch. We are dealing with infection, inflammation within the CSF, which can, like we had hypothesized earlier, can present in such a manner. And now trying to produce a laundry list of different organisms, viruses you heavily mentioned, if I remember. How about bacterial organisms? TB comes to mind. We did have a VMR with TB with heavy mononuclear cellular infiltrate into the CSF. Here, like yesterday, we had pleocytosis. Here we have mononuclear cells. Syphilis also comes to mind. HIV comes to mind. And then of the non-infectious categories, multiple sclerosis also comes to mind, although I don't think that's at play here. But those are the few infections that come to mind. I think neuroborreliosis maybe also attributed to that as well. But then this warrants some maybe PCR on the CSF as well, and further testing and gram stain as well of the CSF to see if some sort of some bacterial morphology or some genetic material of a virus can be evaluated from the CSF to get us a diagnosis. But let's see what the MRI shows.
We have a picture of it if you'd like us to share it.
That sounds
Oh,
awesome.
sure.
I don't know if I'll be able to interpret it, but let's take a look. It's all you,
Or for your own interest, maybe than anything.
Robbie.
If we might need to,
Oh, Ravi, can you make them co-hosts?
yeah.
Thanks, friend.
They are co-hosts. Yep. You able to share? Press the share at the bottom.
Go back to the Zoom.
It's on there.
Oh, sorry, one moment.
Hey, Ravi and I shared we were talking. Zoom got like a major upgrade, so it looks very different on our end at least.
Okay. Okay, can everybody see that?
You can go ahead, Dr.
Yes.
Talk about the findings.
So we also you guys brought up some very good points. We also sent a encephalitis PCR that we have at our institution. Obviously takes some time for it to come back. But the MRI came back before before the encephalitis PCR. So I'm not sure if you guys can see the abnormality. Yep.
Yeah, it looks like a hyper intense signal
Yeah.
within the spinal cord. So there's no compression, and having that sort of hyper intense signal within the spinal cord, that does appear like transverse myelitis, if that's what was read.
Yes, it was read as transverse myelitis. And so it was, specifically, so it was read as transverse myelitis with patchy multifocal T2 hyperintensities within the cervical and thoracic spinal cord. So,
So this is a
It's-
pretty it's
yeah.
pretty extensive then. It's patchy too, so it's pretty cervical, thoracic. Well, okay. Wow. Um, any other information? This is, I think, enough to chew on, but anything else?
Yeah, so our Cryptococcus was negative. We checked for tick-borne illnesses because he was camping in the Midwest. That all came back negative. And then when the encephalitis PCR came back, that kind of gave us the final diagnosis. So if you want me to reveal it, I'm happy to.
Yeah, right. I feel like we've speculated it. I'll just say, this fits a viral sort of picture. Like viruses are very classic to kind of cause myelitis like this, and the syndrome here is really acute, progressive in a traveler. So I think and I know TB can do a lot of things, but just the tempo of this, and then with the signature too of the leukopenia and the thrombocytopenia, that's like a pretty strong signal when in looking back for a virus. So yeah, I think our answer is going to be there, Ravi, but I don't know what exactly this is going to be. I'm very curious.
Yeah, I think we're getting pretty close. So it requires sort of discussion over the causes. So infection was pretty much heavily what we were thinking about, all the different viral possibilities. But then a few, I think Gerardo was mentioning in the chat, a few inflammatory conditions to think about. So things that could possibly cause something like this. I mean, MS, I was thinking about mononuclear cells. NMO comes into play, ADEM. There's no history of vaccination in the patient. So if the post-vaccination conditions can manifest with transverse myelitis. This was one of the first cases like 4 years, I don't know how many years ago I presented to Rabi and Reza of a patient with substance use disorder presenting with transverse myelitis, and it presented in such a manner. And then the differential was quite broad. And then the MOG antibody association, there is a condition, I think NMO, like Gerardo mentioned, something to think about. And then there's autoimmune phenomena, lupus, and mixed connective tissue disease. If I remember, there's a laundry list of different causes. But here, definitely, I'm all aboard the viral train here, and I think if doing a PCR, something can come out, maybe just HSV could be a common cause, or like you mentioned, maybe the camping and West Nile virus and so on could be at play here. But I'll swing the mic back to Dr. Mehta, to give us the last, or to give us the final diagnosis.
Thanks. And Kapil is fine too. So the encephalitis PCR came back positive for varicella. So he had varicella VZV induced transverse myelitis as our final diagnosis. Obviously ID was following all along, and so they started treatment for him, and his lower extremity weakness improved, and he was discharged eventually to a acute rehab facility. You know, one thing kind of reflecting back on this, we didn't really check a varicella titer, but because we already knew he had varicella PCR, and so we didn't bother checking it because we're like, just to start the treatment. So, but we probably could have checked it as a opportunity.
Wow, this is such a cool case. I feel like VZV is up there in terms of like the great mimickers. Vasculopathy in the brain, transverse myelitis in the brain. Super unexpected. I love this case so much. It's interesting. It's hard to put your money down on something unless there's a particular exposure. All we really had was some kind of like broad signals that this was a virus in a couple different forms, like the cytopenias, the mononuclear predominance, the cytosis in the CSF, but amazing case. Ravi, what do you think?
Yeah, same here. I really appreciate Deepa, Caitlin, and Dr. Mehta bringing this case and educating us. I was just reflecting on the journey. Just this is a patient that can come to an emergency room. Future interns, you may see this on a average admitting day in your emergency room, and you're like, where should I start the workup, the diagnostic process with this patient? And this just exemplifies the mechanistics of reasoning, where what kind of testing or what sequence should we go in to verify and refine our hypothesis here? Because right off the bat at the beginning, I was like, oh, stroke. This could be a possible stroke here, but then integrating the epidemiology, the background, this you could definitely recognize this is a sick patient with the seizure, especially, and the headache and so on. But yeah, I think you did a fantastic. This just shows the level of education at your institution, the workup, or the high value care that was implemented in this patient in the investigation of trying to figure out what's going on. So I definitely applaud your institution and the fine residency in working up this patient. And any final words, or what did you learn, Deepa, Caitlin, or Dr. Mehta, from this case?
I thought this case was so interesting because it reads like it walked down a U world. You know, you've got the patient who spent time camping, who's originally from China. You know, it could be anything when you first start, and to get to the end and figure out that it was varicella was such a surprise. I thought it was really interesting. Neuromuscular disorders, I think, is something that is a weakness of mine. So it was a really interesting case to work through, and Dr. Mehta did a really good job of guiding us through it as well. I definitely learned a lot.
Yeah, I agree with you. I mean, seeing his initial symptoms, I was also thinking stroke, especially when he initially presented to the ER. And I think that that's what we were all kind of basing it off of when he went to the CT. So it kind of showed us not to anchor and keeping our differentials broad and getting a good history. And
something that still kind of puzzles me a little bit is how much of an effect the dexamethasone had on the case, you know, how big of a player that was, that he was taking that prior to presentation. So that's something I've been continuing to kind of mule over a little bit.
All fascinating points here. Yeah, we forgot about the dexamethasone. That's a very valid point. And we'll close it out with the fabulous Elena with teaching points.
Ravi, I think Dr. Mehta was going to share some.
Oh, okay, Dr. Mehta, sorry.
Oh, no, it's okay. I was just like, this is actually my first case of VZV induced transverse myelitis that, you know, I've seen in my 14 years, but like it is not very common that so, you know, but it is very important to keep this as one of the possibilities for a transverse myelitis. Because when we got the PCR back, I started looking up, like, is there a correlation with varicella or VZV and transverse myelitis, and there's been a few case reports out there, and so that kind of solidified our diagnosis.
Wow, thank you. Elena, teaching points?
Yes, thank you so much for such an educational case, Deepa, Caitlin, and Dr. Mehta. I'm actually working in an ED right now, and I'm sure that like it will help me to when I see a patient like this. So Andrew started us off with this new mnemonic, which is very helpful for secondary headache red flags. And this patient actually had 3 red flags. They had systemic findings, multifocal neurological deficits, and being over 65 is also a red flag. With the patient having a seizure, we also have to include the MIST or the VMIST mnemonic for AMS. With the urinary retention and the lower extremity weakness, we were also thinking about spinal cord issues like myelopathy due to a compressive problem, or also metabolic problems. And we had a very interesting RLR recently on a patient having pyelonephritis that then had an epidural abscess through the Baston's plexus. I was also trying to capture some of the teaching points in the chat, and Yusuf shared with us that dexamethasone, if taken like for a longer time or in high doses, causes impaired T cell function, and this makes the patient prone to intracellular infections. And I've written down TB, listeria, nocardia, fungal infections, and actinomycosis, but in the end, I had to add viral because, of course, this is an intracellular infection as well. In the labs, we got leukopenia back, which is, can be typical for a viral infection, but Andrew was also tracking arbovirus infection, especially with the extensive traveling history of this patient. We had a very interesting case yesterday as well, and we're focusing also on lung and brain infections syndromes. And I will not read all of those infections, but they're very interesting to track in these patients. We then got back the lumbar puncture, and we saw that there were a lot of mononuclear cells in the CSF. And we were thinking of viral fungi and atypical infections like Listeria brucella, but viral was on our was high on our differential, and in the end we learned that this was actually VZV and just transverse myelitis. Thank you so much for bringing this interesting case and letting me do the teaching points.
Thanks so much,
giving us this opportunity to present it.
Thank you for coming again. It's very nice to meet you all. Come back. Ravi, it's been a pleasure.
Yeah, been a pleasure, Andrew. Thank you again, Deepa, Caitlin, Dr. Mehta. Absolutely loved having you here. And please bring another case from your neck of the woods again to educate us. Thank you. Take care, everybody. Bye.
Absolutely. Thank you. It was nice.